Welcome to today's webinar, Preventing Denials Together, Provider and Payer Alignment. This is Rosalind Lewis, HFMA's Program Coordinator, and I will be moderating today's session. Now it is my pleasure to welcome today's speakers. Terri Meier is the Assistant Vice Chancellor of Revenue Cycle at University of Arkansas for Medical Sciences. Terri is an accomplished healthcare revenue cycle leader with over 43 years of experience. She is responsible for overseeing and directing the overall functions of the UAMS revenue cycle, including integration, strategic planning, and overall performance. Terri contributes to developing revenue cycle talent by instructing the Revenue Cycle Certificate Program for UC San Diego Extended Studies, and facilitates the sharing of knowledge and best practices by serving as the core shared business office best practice leader. Will Richter is the VP of Client Success at Revco Solutions. Will brings nearly 25 years of experience in healthcare revenue management, with a career shaped by a passion for client relationships and delivering results. He began his career diving into complex claims work at a leading attorney-based RCM firm. His career took a valuable turn when he joined Regence Blue Cross and Blue Shield, gaining critical insight into the payer side of the healthcare equation. Will went on to hold leadership roles with increasing responsibility, including Vice President of Client Management and most recently, Executive Vice President of Operations and Client Services. In these roles, he spent over 7 years helping healthcare organizations navigate operational challenges, improve financial performance, and build lasting partnerships. And with that, Will, I'll turn the presentation over to you.
Thank you, Rosalind, and good morning or good afternoon, depending on where you are. We purposely scheduled this for 11 o'clock Pacific time so that no matter whether I said good morning or good afternoon, I would be correct for somebody. Terri, it's great to see you today. Terri and I first met about 20 years ago. We were at an Oregon HFMA, and we were speaking about denials. And at that time, there were a couple of different presentations at the HFMA event, one of which I was presenting on. And you'd like to think that as we circle back here almost 20 years later, that it's gotten easier and that there would be less to talk about and that we would have solved everything. But unfortunately, here we are, probably with more information than we've ever had. And so we're excited to speak to you today about being able to combat and overturn the denials. Right, Terri?
You got it.
Let's start, because of the changing landscapes and everything that we've seen, let's start right away with a polling question, as Rosalind referred to at the outset. And here's the polling question. You will notice there is really no wrong answer on this because there are so many different possibilities and roads that we could have gone down. So we're going to start here with what trend in the current denial landscape concerns you the most? Is it A, the increasing volume of denials for medically necessary care? B, growing complexity and inconsistency in payer requirements? Or C, rising administrative burden on clinical and revenue cycle teams? Terri, while everybody's answering, what would you say is the trend that concerns you the most?
I think for me, it's the volume. We struggle with just an overwhelming amount of denials, and it's really, one of the bigger threats, above, the reimbursement, cuts in reimbursement and lack of staffing. Because in order to overturn that denial, we've got to touch it. And the sheer volume is really the thing that is impacting us the most.
I would agree with you, and I'm curious to see as the answers come in here. It looks like we have a tie for a couple of them. I'm with you on the volume. I think that something I read recently highlighted the rising denial rates that providers have reported, and basically from 2022 to 2024. the percentage of providers reporting an increase in denials jumped from 42% to 77%. Now, that's a pretty staggering figure. Some might think that's actually low. They might have think that the denials increased 100%. But they said largely, the article that I read, that it was due to more complex payer rules, increased documentation requirements, and shifting reimbursement models. Also, a comment that I read that I thought was very, very relevant is that denials now are more not just an error like they were when we were talking about it 20 years ago, when you would point to maybe somebody on the front end who didn't enter something properly, but now more of a systemic issue versus just an error. Would you agree?
Absolutely.
All right. Well, I think that we've, there we go with the polling question. Well, that was so much fun. Terri, why don't we do another polling question just to keep the flow going here? So we'll wait for it to come up. And here's number 2. Which hidden cost of managing denials has the greatest impact on your organization? Is it 1, staff burnout and turnover due to administrative burden? 2, delayed patient care and reduced satisfaction? Or 3, opportunity costs of time diverted from strategic initiatives? And Terri, as we did with the last one, while we're letting people answer, what are your thoughts on that?
My answer is 3, the opportunity cost of time diverted from strategic initiatives. I think, the lag in payment is just resulting in our inability, to reinvest in our organization and our people.
I would agree with that. I had a client many, many years ago in Las Vegas, and the gentleman has since retired, but it was back before we had all the CBOs and all the chains, and it was sort of one hospital with the staff at that particular hospital. And I used to ask him what the cost was for him of managing denials. And I'll never forget what he would always say is time, talent, turnover, repeat. And what he actually meant by that was that he was very proud of being lean. And it was before the lean that we know in this day and age in terms of how you're staffing and running your operation associated with Six Sigma or what have you. He had just enough people to manage the number of claims that he had based on what he knew he was getting every single month. And he was staffed somewhere in the neighborhood of 750 or 1,000 to 1. And those folks would do the billing, they would do the follow-up, and they would do the appeals. And what he said was, because he had the caseloads allocated in such a way that they could hit everything timely that was on their work queue, anytime he got a denial, that cost time, right? So suddenly, if you were used to working X number of accounts a day and your first pass denial rate grew, well, then you had X number more accounts that you had to work.
Yep.
And then what he would complain about is the talent that would be required to overturn those denials. Because many times, if it's an auth issue, if it's a med nec issue, you have to go involve a clinical resource. And then that clinical resource would be taken away from something that they were already working on. And then what would happen is, as the volume grew, you would get frustration among the staff. And so you would have people leave, hence the turnover part of that statement. And then it would all
the same
repeat
thing over
itself.
and over again without it being changed.
Exactly. It's a kind of a vicious cycle. And it's funny because that was also many years ago, like I said, before the chains, before the CBOs. But I would think, and you know better than me, that's probably still true today, correct?
Yeah, absolutely. I know. It just gets, frustrating. The work queues keep growing and it's the same denials over and over again. And it causes our staff to be just so dissatisfied with their job.
And I think we can see from the answers here with 51% highlighting the opportunity cost of time. Most people agree. As we said at the top, there is no wrong answer. We touched on staff burnout. We touched on reduced satisfaction. There's no wrong answer on these polling questions. Terri, I'm going to ask you a question. You've been at OHSU. You've been in different time zones, different coasts. With respect to either where you are now or where you've been previously, How have denials affected your organization financially and operationally specifically? And what steps have you taken around things like root cause identification and prevention?
Yeah, I mean, again, I go back to the, the time value, I mean, of the accounts receivable. As the receivable gets older, it's less likely, to recover on that balance. Some of the things that we've done here at UAMS is really targeting prevention. So we've put together a denial prevention team, and the team is separated in both HB and PB, because again, I'm over the enterprise revenue cycle. So I've got a prevention team that is dedicated to HB denials, and a prevention team that's dedicated to the PB denials, because at times they can be a little different. We've implemented quarterly at the start. I've only been here about 2 years, so it's kind of a work in progress. But these quarterly service line meetings with the service lines, again, we are trying to bring to the table some actionable information in which to create problem solvers, of those service line directors, because sometimes, it does start with those physicians, those clinicians in those service lines. And then with the advent of, we're an Epic shop. So with the advent of, Slicer Dicer and the dashboards, we have created individual denial dashboards specifically for those service lines. So they can go in and self-serve. So we're trying to teach them how to fish and be our partner, in this journey, this denial prevention journey. Get them acquainted and proficient, with Slicer Dicer. If they have a question, they can just pop in and try to answer their question. But I specifically require my team, to go to those meetings, having done the analysis and the research, and with actionable information. We have primarily focused on, preventable denials around medical necessity, authorization, and non-covered. We're starting to expand into other denials now, as we have made progress in reducing some of those initial denials. We also have, a couple of multidisciplinary denials team that meets periodically, and we've got clinicians, contracting. So it truly is multidisciplinary, because these denials involve all of those aspects: the clinical care, the contracting, and the billing of that service. So those are some of the things that we've put into place to try to mitigate those denials. One of the I think the things that I found here that I haven't had the opportunity to engage with in my other organizations, UAMS is so dedicated to, turning these things around. We actually have a physician champion that has dedicated one day a week, to working with us on denials, clinical documentation improvement. She actually writes a newsletter for the physicians, and in that newsletter, we have a denials corner that we can communicate, some of the, the upcoming things. We're trying to be more proactive instead of reactive. I've added a reimbursement analyst to my revenue integrity team, so we can get ahead of the changes with the payers, to let the clinicians know if it's something, in their workflows that need to change. And she does, when it requires, she does these peer-to-peer educations with the clinicians as well, because I think the education is better received from peer-to-peer than it is from somebody from revenue cycle. So those are a couple of the tactics that we've put in place here at UAMS to try to mitigate, transition from reactive to proactive in our denial management.
Thank you, Terri. Those are excellent answers. I kind of chuckled hearing you say that some of the avoidable ones are authorization, medical necessity, and eligibility. In some cases, those can be more of the complex ones to overturn, and we'll focus on that just a little bit down the road. I'm curious. One of the things that I've heard as far as an operational impact of denials is the data silos that to some extent exist from organization to organization, and specifically, I'm talking about a lack of integration between clinical, billing, and payer systems, hindering the ability to have effective outcomes. Have you seen that in your experience or no?
Well, I mean, I think, at being an Epic shop where the integration part is part of what we're really working on. I've also hired a revenue cycle informaticist on my team, and that's her primary role. As said in my bio, part of my job description, the requirement that UAMS has put on me is integrating revenue cycle into the organization. And I think there is a lack of understanding, that everybody, clinicians, the person that's checking in the patient, everybody is revenue cycle. They have a piece of making sure that account gets paid at the end of the day. So I think, again, with the denial dashboards and the slicer dicer, really trying to integrate those ways in which the clinicians or the service lines or the ambulatory, leadership can dig into and get that information, single source, and I think that's one of the most important things is that you have one source of truth. You're not, going out to a Power BI or dropping information into something. I think what I really like about it is they're going into Epic. They're getting the same number that I'm getting out of the same system.
You mentioned denial management meetings that you have with your staff and with other departments, and I think that that's so key. I find too often the experience is one where they'll identify an issue, a particular organization, and they'll trace it back to the front end. However, in that scenario, and when they're meeting about it, folks from the front end sometimes aren't at that meeting, which I sort of chuckle because it becomes a bashing of somebody that's not there to defend themselves. So have you found those meetings to be productive? And with respect to the root cause analysis that you were referencing, does it help you categorize the denials, create dashboards, provide feedback loops, all those things that typically you hear are essential towards being able to prevent and overturn the denials?
Yeah, absolutely. We specifically have a patient access revenue cycle task force that we've stood up here at UAMS. And, again, my informaticist has built a dashboard specific to that interaction of that denial meeting. So when we're looking at denials, we're going into the dashboard, we're pulling the information right there from Epic and, looking at accounts. I mean, really sitting down, working meetings, looking at accounts to figure out what went wrong in this scenario, and then extrapolate that. Is it just this patient, or is it happening, on a larger scale? And unfortunately, I know one, the things I think I commented before, that is the biggest burden is really just spending the time getting the right people to sit down, in that particular time and look at those accounts, one at a time and really root cause what happened in this scenario. And then come up with your corrective action plan, figure out, how big the problem is, and then get it implemented. We have that patient access task force. We meet every other week with contracting, so we can get the payer policy, root cause on some of these medical necessity denials, non-covered and things. And then we have another meetings, and this is how committed UAMS is to denials. Our CM, our Chief Medical Officer, is the sponsor for our inpatient monthly denial meeting. We go over the inpatient denials, the DRG downgrades. And I mean, so they're really committed to, mitigating these denials and however we need to, whether it need to be a physician to change a practice or, a back-end workflow or whatever the case may be.
You answered one of the questions I was going to follow up with, which was how frequently your team met. And I think monthly is a great answer. I've sat in on many engagements where it was quarterly or even in some cases twice a year. And what I found happening was people didn't really remember what we talked about the last time because it's very easy for something else to get in the way. And if somebody had an actionable item, many times, if there were 2-3 months between meetings, that action would not get taken. And if somebody missed a meeting, because that happens, then you wouldn't really have any actionable outcomes for several months at a time. So it's great to hear that you're doing that monthly.
Yeah, my denial prevention team, we taught them, the SBAR format, and again, it's a lot of it's communication too. And utilizing a standard format of communication in which, you can bring the other party along with, which, SBAR is a great tool in which to do that, has served us well. And then we take that and, go into our A3 and, our corrective action planning and everything. But you're right. We did quarterly meetings with our service lines, and we've heard great engagement from the service lines. And I think it's gone so well. Now they're asking to have them more frequent than quarterly. To your point, I think quarterly is there's too much time in between.
Absolutely. One more question, just curious, what are the most, because it sounds like you have a process, which is half the battle. There are many organizations that don't, or the communication isn't there. What are the most resource intensive aspects of specifically managing denials within your revenue cycle team?
Yeah. And I think it's with my prevention team, because again, with these service lines, I've asked them to do the research, have actionable data. And, with the SBAR, the R is recommendation. I'm asking them to actually come to the table to have a recommendation. We send out the information ahead of time so the service line can, understand what it is that we will be discussing. And then, we do a little, recap of what we're doing, but then spend a lot of time on that recommendation. What are we going to do to prevent it? So I think the labor intensiveness comes from that root causing, and putting, doing the situation, the background, doing the analysis, and then coming up with the recommendation. But I think without putting in that effort, I don't think we would have gotten the level of engagement that we have gotten from our service lines.
Excellent. On the partner side, my answers would be very similar to yours. So I think one of the most resourceful, intense aspects of appealing a denial is the amount of effort that goes into identifying what the root cause is, what's actually being denied, how you effectively appeal it, what part of the medical record on a MedNec denial is going to help you get that overturned. I used to chuckle when we would see requirements in contracts from different clients that we had that would require 70 to 100 appeals a day. And I would say, and usually be on the positive side of the outcome, which was, if we're doing 70 to 100 appeals a day, we're probably not doing them effectively, because there's so much that goes into being able to overturn that denial. It's just impossible to get that many done. Additionally, you have to be able to root cause them, because part of the value add that you have on the partner side is being able to tell your client, where are these coming from? Where did they originate? How do you avoid them in the future? And then also training the staff that's working those denials. And I think whether it's your side on the provider side or my side on the partner side, you want to be able to have people that are comfortable with the issues that they're seeing, and learning how to combat them, learning what the laws are in their respective state, what the contracts say, because an authorization denial for payer A is not the same as an authorization denial for payer B. There are so many different requirements, and it takes time to learn all of that. So I think the training process is huge.
Yeah. And some of that only comes from, digging in and learning it, and just the repetitive nature of some of these, denials provides the opportunity to gather that knowledge. But no, you're absolutely right. Our denial prevention team, they are kind of like mini in-house consultants for these service lines to try to, mitigate these denials, because it's impacting our cost to collect. It's impacting our net collection ratio, and it's just overburdensome.
Absolutely. Absolutely. Let's look at denials for a second from the patient perspective. And I'll ask for a polling question at this point. And here's the polling question. What percentage of your patients fully understand why a claim was denied and what they may owe? Is it 1, less than 25%? Most patients are confused or unaware. 2, 25 to 50%. Some patients understand, but many need help navigating. Or 3, over 50%. A majority of patients are informed and proactive. Terri, what would you guess the majority of the folks are going to put here as
probably less than 25%. Most patients are confused or unaware.
I'm going to agree with you there. And in fact, even at the outset of this webinar, we talked about how we've been discussing this for 20 years. I still get things in the mail. I would like to think I know what I'm talking about on a lot of this stuff, but I still get correspondence from payers that will make me scratch my head a little bit. So for example, I have a 13-year-old daughter. She goes to the urgent care quite frequently, right? She plays soccer, so she gets hurt. We have a hand issue, a foot issue, a leg issue. And every so often we would get a coordination of benefits request. And that coordination of benefits used to just say, please let us know if you or anybody on this policy is covered under any other insurance, right? It was pretty standard. Well, we got one just the other day that asked if there was anybody else in the household, and it listed spouse as an option, and that's me. And it said, do they have any other insurance, regardless of whether my daughter is actually covered on it or not? And so I look at that and I say, okay, that's just another step that you have to go through in order to get this turned around. And I think what a lot of patients don't understand is that as I'm trying to get that answer out to them and scratching my head saying, why do you need my insurance? It's only me on my policy. Why are you even asking for that information? Mm-hmm. That claim is not getting paid. I think you've probably seen that develop more, if you will, over the years, correct?
Yeah. It, they when they get their EOB, I mean, I think the thing that they're concerned most about is, what's in the amount you owe box, right? I mean, not all denials get passed on to our patients. But if the amount that they owe is different than the amount that they think they owe, they're calling customer service. And I think that's where, customer service has become, a place where you have to have knowledge workers, not just regular customer service, personnel. They need to be able to answer that patient's question. I know, not only the COB, but, when they've got their max benefits. I mean, some of these things that payers are pushing on to the patients where, cost shifting, on some of these services that are non-covered. If they are adjudicated, with that PR, that it is the patient responsibility, that patient has no idea. I mean, really, I'm sure they have no idea what their benefits say when they're coming in to get that service. It's only after they get the bill that they have that question. I think a differentiating factor for most organizations is, having a great customer service department that can help that patient navigate through, all of that confusion.
That was very thorough. You answered one of the questions I was going to ask, which is what is the biggest barrier facing patients in understanding a denial? And I think you hit on it. Just to summarize, I think one of them is obviously the complex and technical language that you alluded to. Most patients don't understand insurance jargon. They may understand lack of medical necessity, but I don't know about you, but if I wasn't in this industry and I saw something that said bundled code, I would have no idea what that meant.
Yep.
There's rarely a plain language explanation of what was denied, why, what to do next, who to call, how to get it overturned, what's even needed from you, right? So I think that's obviously a big one. And then the lack of transparency, I wish was less of a barrier. I think patients often don't know who even denied the claim, the payer, or was it the hospital? If there was documentation.
A third-party authorization administrator, or it's quite confusing. I have plain language on my notes too, so I'm glad you hit on that, because that's just so important. Our some of our patients, when they're getting their insurance, the only thing that they're first concerned about is, what's my deductible? What can I do with my deductible? I don't, after that, I'm not sure how in depth that they go, unless they've got some sort of pre-existing condition or something, where they go into, then what are my benefits? What is covered? What's non-covered? But first, it's what is my deductible?
Yeah, I agree. And then I would think, and this is a little bit of a tough question, but I'll ask it anyway. I think that these denials that the patients see probably impact your ability to maintain trust and continuity with your patients on one side or the other. I think that's only natural if somebody has a denial and they don't really know what to do with it or where it's coming from. I think that trust and continuity does become impacted. Would you agree?
Oh, absolutely. Because they, again, when I was over customer service at UC San Diego, our single billing office, and one of our guiding principles that I had for my team was, our patients, we need to show them, we need to coordinate for them. It's on us. And I think, with this price transparency, regulations and things have become, patients now expect to have, this information prior to service delivery. And when they get hit, with a non-covered or, max benefit bill, afterwards, it degrades the trust, because they think we should have, show me, know me, coordinate for me. And unfortunately, it's on the organization to take on that role.
And I think, I'm happy to see some of the technology advances that are being made in order to make things a lot easier for patients. But then I was just in Virginia visiting my mom and dad. My dad is 83. I was telling him about some of this technology, and he was like, why are you even telling me this? I would still have a rotary phone if things were in my space. So I think it can be confusing, even with all the advances that we're trying to make on the patient side. Let's look really quickly as far as, so when I talk to different revenue cycle leaders and we talk about solutions to some of these denials, I hear a lot about payer strategy, collaboration, increased transparency. So let's jump to another polling question here. And this polling question, What do you believe is the primary driver behind most insurance claim denials? Is it A, cost containment, making healthcare affordable in a complex system? B, regulatory compliance, in other words, avoiding legal or policy violations? Or C, profit maximization, in other words, protecting financial performance and shareholder value? So in other words, what drives the denial on the insurance side? And Terri, before I go to you, I know it was mentioned at the top of the hour that I spent some time working at Blue Cross. And what was very different for me during that experience is I've spent most of my career working with hospitals appealing denials, thinking I was making the system better, and I was. But on the insurance side, it doesn't get looked at on a 180 from what we're talking about in terms of the appeals. On the insurance side, all of the discussion surrounds the member, doing what's best for the member, keeping the costs affordable. And sometimes I would chuckle because I would think to myself, there might be this animosity that only exists on one side. It doesn't necessarily always exist on the other side. And I think what we find is when we have more collaboration and transparency, we can make some progress together. I've seen the meetings where you get everybody in the room tend to result in better outcomes than when there is no representation and no collaboration. Would you agree?
I totally agree.
So let me ask then, what's your experience working directly with the payers to resolve denials? And throughout your career, have there been any collaborative models that have worked really well?
Yeah, it's a little all over the board. Currently here at UAMS, I have to say, some of the payers here are a lot different in the mid, South than there is on the West Coast and East Coast. I'm finding it actually a lot easier to work with some of the payers here in Arkansas. I think the thing that moves the needle is you got to have good data. You've got to be able to show the trends and have the examples. The payer dashboards and things like that. That tends to move the conversation when they're especially when they're confronted with examples. I think that's key to have those. But just the data to drive the discussion. I think where I found it to be most collaborative is when we are talking about administrative burden, because we both have the same burden. I think in the news you're seeing insurance companies lay off people just as much as healthcare organizations are laying off people, and I think it's just so unfortunate that we can't make progress to close that gap on that administrative burden, because there's just so much of it.
I agree. And I think what we're starting to see, at least in my experiences with clients, is more, and it's a good trend, proactive payer collaboration, which includes regular joint meetings to review denial trends, real-time feedback loops for claim status and documentation issues, versus reactive trends, which is what I saw a lot of in the past. And what these meetings do is they actually help bring out contract alignment, because so many denials are buried in, as you know, the provider manual, which is incorporated by reference into your contract. And unless you read all 500 pages of that provider manual, you're going to miss a step here and there that needs to be taken in order to make your life easier for all of your representatives. I'll tell a quick funny story. I used to work with Blue Cross in the state of Michigan, and we were working with a client there, and we had a large low balance project. And at the time, this was many, many years ago, and there were a lot of low balance denials, and nobody really did low balance well, right? I mean, the high volume low balance was one of these things that you took on, and you did the best you could, but you couldn't actually put the same utilization review nurses, attorneys, and what have you on those accounts. So we ended up working with somebody that sent a bunch of letters on all of the different denials that we had received through this project. And I went and sat on a payer meeting. I was called to a meeting with the organization and with Blue Cross. And as I sat there, the Blue Cross representative came in with one of these dollies and 5 bankers boxes that they brought in. And I just kind of looked and I realized what was happening. And I said, are those all from us? And she said, wait, I'm not done. And she brought in 4 more dollies worth of boxes, and they were all appeal letters, and they were all regarding the tens of thousands of denials that were part of this project that we were working on. And she came right out and said, look, there's no way we're going to be able to review all these letters. And she pulled out some of the letters and she's like, I don't have people that can review all of this. And it was a proud moment for me because I looked at the VP of Revenue Cycle and I said, well, you can't say we're not working your accounts. They just brought 4 bankers boxes, dollies full of them in here to look at. But the reason I tell that story is because what it led to were more consistent meetings with Blue Cross where many of these issues ended up getting resolved. And then going forward, we didn't have to have episodes like the one I sat through because the denials weren't occurring in the first place. So I think, to your point of collaboration and consistency and transparency, that's the road definitely that most people are taking. Is there anything?
Yeah, we struggled with, cost charge line audits, especially when an account hit an outlier. And one of our insurance companies, came to the table with us, and we were able to argue, point by point, and even with our, chief medical officer and proving that, this didn't fit the definition of routine. And we've had some payers, actually, they call them quirks for whatever reason, what a term, but they've written these rules. So then now when we submit our claims, then those items are not denied as line item denials, because sometimes it's just a meeting of the minds.
Agreed. I saw something just pop up in the chat. It's the first time I've seen something pop up, so I'm just going to answer it really quick. It was, what was the outcome of all of those boxes? Well, the outcome of all of those boxes is we went back to the drawing board and we worked with our facility to sort of group by root cause, by denial type, by issue, and then via spreadsheet work directly with the rep to get those that could be overturned. So it was a good example of the collaboration that we had just mentioned, and we were able to implement some standardization throughout the processes. And I'm curious, Terri, in terms of transparency with the payers, what would you like to see standardized as you work through the issues with your team?
I mean, just fundamentally, just use the same CARC and RARC code the same way. Just standardization of what you're denying and why you're denying it. Because then I can engage with you. But if I have to figure out, they used this code, but what they really meant was this, but they used a code that meant something else. I mean, it takes me longer to get to the point where I can have a conversation with you, because there's just no standardization in that utilization.
I agree with you 100%. I've had this discussion with many revenue cycle leaders, and the 2 things actually, well, 3 things I would say. So the first is, as you said, transparent denial reasons, clear standardized codes with plain language explanations, specifics, as we talked about with the patient EOBs, specifics on what is either delayed, denied, what is missing, what is insufficient. Number 2 is uniform documentation requirements. As you know, it can vary from payer to payer, issue to issue. And then the third that I hear quite frequently is standardized prior authorization processes, because as you know, depending on the payer, from payer A to payer B, it may be a completely different process. And I'm sure that's been your experience.
And it's the chaining of it too. You know, I mean, medical necessity, you send records, then you send the records, now they got another question. So, I mean, it's just the continual, the chaining of asking for additional information. Like you said, we just can't cut to the chase. You know, we've got to elongate the chase.
So we're not quite there yet in terms of the standardization. So that still leaves us to developing solutions, either for yourself with your team or with a partner like us. Question for you: have you implemented, as we see, and we both were at the annual, I keep wanting to call it A&I, at the annual in Denver recently, and we saw many organizations, as you walk up and down the aisles in the exhibit hall, touting AI and automation and machine learning. I'm curious, have you implemented any automation or AI tools to help manage these denials? And if so, what's worked and what hasn't worked?
You know, we're an Epic, you know, Epic first is our guiding principle. So, I mean, Epic has a few tools that we use, their likelihood to recover and, you know, some of their enhanced claim statusing. I think the thing with the likelihood to recover, it does get the noise out, you know, so my team works, you know, those higher return on investment accounts. So, but, you know, the model learns on your past behavior. And, you know, we didn't have enough staff to work these denials. So our past behavior was, you know, if the denial didn't, you know, result in at least $300 of reimbursement, we adjusted that because we just didn't have, you know, the team members to work them. So that's what the model's learned off of. I mean, so we've got to change our behavior so then the model can change its behavior too in you know, coming up with that likelihood to recover. We've implemented, you know, a little bit of the AI on writing the denial letters. I know Epic's got, you know, something coming where it's going to embed the payer policies because I think they've recognized how important those are. And we use a little AI on the inpatient side of our clinical documentation improvement and our DRG. I have a nurse that does all of my DRG downgrades. And we have an AI tool that is helping her construct those appeal letters, because you can imagine inpatient, you know, the documentation is absolutely overwhelming. And to your point, we're getting more and more of those, you know, like 130, you know, a month, and it takes, you know, 2.5 days to get through one, you know, to find all that documentation. I think that, you know, where organizations are going to be ahead of the game is being an early adopter of that, and, you know, to augment that human resource.
Would you agree? One of the things that I've seen in the different publications is talking about predictive denial prevention and utilizing the AI models, as you referred to analyze claims before submission, to flag things like missing documentation, coding inconsistencies, potentially authorization gaps. And I think I read that people thought that essentially 82% of all denials could be avoided as this AI tool developed further. So specifically for avoidable denials, most of them could be avoided with enhanced predictive denial prevention. Would you agree with that?
Well, I mean, I think it's a good place to start, you know, to root cause it, but to prevent it, you've got to change the behavior, you know. I mean, so I think it gets us closer. But I mean, we got to leverage that and, you know, take it all the way. Because, you know, again, if we're providing non-covered services, that's a change in physicians' practice. You know, when this patient comes, I always run all these lab tests, and, you know, it doesn't matter to that clinician if 3 of them are denied as not covered. This is just the way he practices medicine. So I think it will get us part of the way there, but I don't think it's going to get us all the way there, because there is a change in behavior that has to come as a result of that information.
finally, Terri, because I see we have a lot of questions down at the chat, and I just looked at the time, and this is sort of again, it's one of these. There's no right answer questions. What does success look like for you and your organization?
Well, having no denials is probably an unrealistic expectation. So that's probably not going to happen. But I think, just that transition, to, proactive from reactive and mitigate as much as we can. I think, we've got to leverage automation where we can. To address, our cost to collect in this denial space, because it's killing us.
Agreed, and I think on the partner side, we would use many of those same metrics to define success. So basically, operational success, a low denial rate, fast resolution time on appeals that we're involved with, financial success, helping you increase your net collection rate, correct, achieving your goals, your cash goals, and then hopefully overall reducing your cost to collect through efficiencies and eliminating some of the administrative burden.
Yeah, exactly. The KPIs that we manage are our initial denials, our insurance collection ratio, and our cost to collect. And it's our days and our aging too, because again, there's the cost of that direct cost of that rework, $25 to $117 per, appeal on average. But what that doesn't include is all the overhead. How much money does it cost me to carry that balance until I can get it overturned? I mean, that's the piece that we need to address, is that time value of the receivable.
Well, Terri, time flies when you're having fun, right? That's what they say. And let's not wait 20 years to do this again. I believe we have quite a few questions. So just in the interest of time, I see we have 8 minutes left. Maybe we can get to some of those questions, Rosalind.
Sure. Thank you to our speakers for that engaging presentation. And I'd like to invite those listening to enter your questions in the Q&A box located on your computer screens. And we will take our first question. Regarding the resource-intensive aspect of handling denials, what documentation should we be sending to the payers with our appeals? It seems like we keep getting requests for additional information, which just stalls the review process.
Yep.
Great question. Terri, I'll let you go first on that.
Absolutely. I mean, again, this is where the standardization and using those claim adjustment codes come in. First, we got to understand, what it is the payer's asking for. But, since we got to know the rules of the game so we can play the game, better than the payer does. And I think, the additional piece that's missing is, again, the payer policy, to show that we are, giving, upholding our end of the contract, and show the unreasonableness of asking for things that are outside of that. I mean, just holding them accountable with their own rules.
Agree 100%, and I think this speaks directly towards the standardization and collaboration that we spoke to a few minutes ago. I would always tell my team on the partner side, and I'm sure anybody on the partner side that's listening would agree, we always would err on the side of over-inclusion versus under-inclusion. There's nothing worse than sending an appeal where you've taken the time to review the issue, you understand the denial reason, you feel like you have a really solid appeal, and then you haven't included one portion of the record that spoke directly to what the denial was in the first place. So understanding what the denial reason is, including the medical documentation to include progress notes, op reports, lab results, imaging, anything if it's a medical necessity denial that would support the medical necessity. If you have a letter of medical necessity from your UR nurse or physician, that helps as well. If it's an authorization denial, proof of the authorization, Or, as you know, Terri, authorization denials, many times they're kind of like a puzzle, which I used to enjoy. Either very often it wasn't that the call wasn't made, it's that the number was wrong, or the number was wrong compared to the service, or the date and the number didn't match, or the scope of the services covered wasn't included in the authorization. So including all of that information so that you can only appeal the issue once and get it overturned. I remember when I was taking the bar exam, the one thing they said is, do it once, do it right, don't do it again. And I think that same holds true for appeals. Good yep. Question. Any others, Rosalind? Do we have time?
I think we have time. What particular denial reason do you find the most challenging to overturn, and how avoidable is this denial issue?
Terri, can I go first on that one?
You sure can.
I actually would say, and I think that's a great question. I think that one of the things that sometimes frustrates me, and I'm sure frustrates you as well, is that some of the most avoidable denials, at least on the partner side, in my experience, are the most difficult to overturn. I'm thinking of cases like timely filing, where there is no, if you look at the notes, there's no basis why a claim wasn't filed timely or an appeal wasn't filed timely. Those are very, very difficult to overturn. Additionally, we mentioned non-covered services earlier. As it relates to an elective inpatient procedure, denials for those would drive me crazy because every step could have been taken to avoid that denial. But if you don't have that information to appeal it, it's one of the hardest denials to overcome because there's so little that you can put in your argument. So those two jump out at me. Terri, I'm curious as to your thoughts.
I mean, some of those, not proven effective, I think are very hard to overturn because the extreme nature of the clinical basis of the denial. I mean, it takes, that collaborative effort with that clinician, some of those medical necessities as well. As long as you can understand the payer policies and make those connections with the documentation, medical necessity is a little easier than I think these experimental, not proven effective. And we're a university hospital. I mean, we kind of get the sickest of the sickest, with all of our research and things. At times we may or may not do things that are not proven effective according to an insurance company. So, I think those for me are the hardest ones to overturn.
These are all very good questions, and I think we're running a little close on time. So with that, we have reached the conclusion of today's webinar. I would like to thank our speakers for presenting and Revco for sponsoring. Thank you again for your participation, and have a great day.